Welcome everyone to today's webinar. We're just going to wait a few minutes and let a few more people in. And I wanted to just say while we were waiting that we are having a NABUS conference in March 27th through the 30th, and it's in Las Vegas. And there is a website, and it's abi2024.org. You can go and see everything about the program, speakers, registration. So we'd be happy to see you there. And I'm going to turn this over to Haley to introduce Dr. Zemek.
Hello, everyone. My name is Dr. Haley Chiswick, and I'm the moderator for today's session. And I am pleased to introduce Dr. Roger Zemek. Dr. Roger Zemek is a professor at the University of Ottawa, a clinical research chair and senior scientist at the CHIO Research Institute, and a pediatric emergency physician. He holds national and international leadership positions in the Pediatric Emergency Research Canada Network, the Canadian Concussion Network, the Living Guidelines for Pediatric Concussion Care, and has membership within, but not limited to, the National Institutes of Health, the 6 International Consensus on Concussion, and NABUS. His research has significantly advanced the care of pediatric concussion and has provided key evidence for the paradigm shift of concussion management to encourage early physical activity and return to school. Overall, we are pleased to welcome Dr. Zemek as our first webinar speaker of 2024. And without any further ado, I will turn things over to him.
Well, thank you so much, Haley. It's always a pleasure to do work with NABUS, and as you mentioned, it's an important part of my career in the sense that I've joined the NABUS board as a volunteer board of directors, and I've really enjoyed working with the amazing leadership team. And I encourage all of you to attend that amazing conference that they have lined up in Las Vegas for this March. So today we're going to do a slightly different spin on research, and don't worry, we'll still be heavy on research. There'll be lots of opportunities for me to present some of the discoveries that our team and similars have done to advance the understanding of diagnosis, prognosis, and management of concussion. But I thought I would go about it in a slightly different way and go about it on my journey and how I built a program of research. And I say this as the leader of the team, but it's definitely a team. And in that sense, I've titled the talk, Many Heads Are Better Than One, a multidisciplinary approach to building a research program. And before I begin, I always think it's important to share my disclosures. I've listed some of the grants that I have received over the years, the support I have for my research chair, as well as my role with 360 Concussion Care, which is a learning health system clinics network across Ontario. So what are the objectives for today's talk? Is to go over using my research of concussion program of research as a case example to apply strategies such that you can build your own program of research in a structured and incremental way, to talk about the importance of integrating teams with broad diversity, the importance of integrating patient engagement, as well as how to establish partners with others, team members, especially those with lived experience. And then lastly, making sure our discoveries are not just those that we keep for the scientific journals or conferences, but to make sure that they get into the hands of the people who need to use it every day, such that we can get people back living and doing the things that they need to do as quickly and as safely as they can. So I always start off talks with this slide, and I know I'm speaking to much converted, but I always start off with the question, who has a concussion? And this is meant for a big audience where I can see everyone's hands, but I raise my hand, and that is one of my first tips for building a program of research. Now, you may choose to do it in concussion, your maybe program or interest of research may be in other types of TBI, such as spinal cord injury, or maybe it's in moderate to severe TBI. Whatever it is, you need to have a passion for that, and you need to enjoy the journey. We know that building a program of research in academia is challenging. As I always tell my trainees, not only do you need to have the willingness to work hard and have some aptitude, but you also need to have thick skin. It's thick skin because we all know grants have, sometimes a 1 in 5 or less chance of success. Same with our journals. And I always tell my students, if you haven't been rejected by a journal, at least 2 or 3 times before it gets accepted. You didn't try for a hard enough journal for the first time around. So you need to enjoy the journey, know that it's going to come with some ups and downs, and it's something that is going to be something that you're passionate for. And my passion comes from my own having 3 concussions in my youth. My next recommendation is, in order to build and grow your program, you need to have access to subjects. Now, it doesn't mean you need to have thousands and thousands, depending on your questions that you're going to answer, but you need to have access to them. So that may be having enough patience to them. Maybe you're a pure scientist and you then therefore need to partner with a clinician. Maybe you're a clinician, but you have only access to patients in one part of the care, you need to partner elsewhere. I thought I would give an example of why access to patients helps for me. This is a paper I published about 7-8 years ago in the journal Pediatrics, looking at ED visits for concussion across Ontario. And as you can see, there was a deflection point in about the early 2011 in which the number of concussions the number presenting significantly increased. And I'm always careful to say that it's not necessarily the number of concussions, because again, to be captured by this data set, you needed to present to a physician in Ontario. And before I forget, if you're curious what those mashup of QR codes are, these are QR code links to the papers that I'm presenting. So rather than having to put all the information of the citations below and take up too much space, and if you don't know how to find it or where to find it, I put QR codes for all of you to be able to hopefully just take your phone, turn on the camera, and you get the link to the various papers that I'm going to talk about. So maybe I'll pause for a second. I know Kaylee does have the chat open. I'm just a way to engage your group early. Does anyone have any ideas in the chat what they think may have happened in 2011 that led to almost the near doubling of number of people presenting to emergency departments or office visits in Ontario for concussion? And Haley, you can let me know if anyone's put stuff in the chat. Any ideas, anyone? So some people say, was it a change in the guidelines? Short answer is no, the guidelines were not a change in the diagnostic criteria. Some people say, was it the concussion movie with Will Smith? And no, it wasn't. I can't prove that this is a cause, but one of the things that we love in Canada is hockey. And in 2011, in January, Captain Canada himself, Sidney Crosby, got his second concussion in a row and then missed 9 months of the remainder of the season. And his question of whether he'd be available for the Olympics the following year was put in doubt. And so was it causative? No. But I can tell you anecdotally, when I was working in the emergency room, I'd ask people why they came, and they said, well, if Sidney misses, my Timmy is the next Sidney Crosby, so I need to know how to get him better so he's not out as much as he is. So it's just a little side thing that I found anecdotally. But we do know that the number of visits quadrupled over a year, which does provide good access to patients. I also bring this up as a great way to develop your program of research. You need to tell funders and show funders what is the problem. And as you can see, starting in 2003 to 2013, there was a quadrupling of the annual visits for pediatrics to concussion. And so that's a good way to make the case of, is there a problem? Well, yes, there is. What's the next tip that I have in building your program of research? Some of the best questions come from patients and families. Other ones come from your colleagues. That's a great example of doctor or healthcare provider A does it one way, B does it the other way, C does it the third way. Great way to say, well, why do we have practice variation? And ground your research on relevant questions. And this is one where I'm going to pause in the sense that I know that when I was working in the emergency department now almost 15 years ago, there was a case I'll never forget. The father had brought in his son, who was 16 at the time, with his 6th concussion. The previous 5 were all due to hockey and other collision sports like rugby. This one was due to just falling off the back of the couch when he was watching a movie, but not sitting on it properly. And he asked me, how long is it going to take for him to get better this time? His last one took 6 months. And I said to him, I don't know. And Dad says, you don't know, because basically inferring you're an idiot. Or he asked me, you don't know because science doesn't know. And I said, I hope I know what the literature says. I don't think science knows. And he said straight up to me, "You better get on that." And I took it to heart. And living through concussions myself, I was passionate about this. So I wanted to get up, be able to answer that question for not only that patient, but all the other ones. And if you look back in the literature, there was a lot of heterogeneity in how predictors were. Some said it was loss of consciousness, yes or no. Other ones said it was duration of previous concussion was the only thing that mattered. There were many, sometimes just what was the total symptom score was the only thing that mattered, but didn't take into account other factors such as mental health or others. And so that became one of my most important things, because if we don't determine who's at risk, it's going to be hard to tailor care, because you don't want to use up limited resources for the person who's going to get better in days to use the same resources on them for the person who's going to take months. We also want to make sure that person who's going to take months, we intervene early to make sure that they get early intervention to get them on the right track. And then the second question I found patients asked was almost all people would say, when can they go back to it, getting back to hockey? Or when can they go back to school? Or can they look at their screens? And these are some things that they need, want, and love to do. But we didn't have answers to, is it safe? When is it safe? How much is too much? How much is not enough? So those were the things that helped formulate my program of research. And this will be foreshadowing some future rounds, presentations that I'm going to be talking later in the rounds. So with regards to engaging families, my colleague Nick Reed and I, who co-leads the Living Guidelines for Pediatric Concussion Care, we wrote a paper with a patient on how to engage patients in research. And this is an example of having family leaders that are affiliated with you, and they can help you make sure that the questions you ask and the design of your studies you ask are relevant to the patients with lived experience and their caregivers. And I think this is an important thing. And if those of you who are curious about this, beyond just the academic paper we wrote, one of the hats I wear is I'm the co-chair of the Ontario Child Health Support Unit, which is to advance child health research in the province. This is a guideline that we wrote for researchers, how you can partner with families in pediatric health research. So if you want to click on that QR code, you should be able to download that PDF and see how do you engage patients and families in health research. And while this is pediatric, it's applicable to all of you, even if you did solely adult care. So what's the next step? So you know what questions you want to ask. You know that you want to get the input of families while you do it. How do you do it? I call this work pre-search. You may say, I've got this question, and it's an amazing question. And many of your colleagues would agree because they've done the exact same research. So it's important for you to do some literature searches, see what questions have been asked. You need to also sometimes see what you've gone from your idea. Are other people interested in this? Is this something only that you're interested in, or it has broad interest? Is this the right time for you to do the research? You may be early on in your career and may not have the protected time away from your high clinical duties to take this on. Or maybe this requires a massive grant to answer this. And so those are the steps that you need to do to take your idea, move it from an opportunity, and then make sure lastly it's relevant. So let's dive into just a few minutes more of this pre-search work, because I think it's really important when you build a program of research, especially in TBI, to make sure others are you the only one doing this? Are there others doing this? And not just as a chance to say, are you the only one? But as this a team of people that have a common share. You can, if there's good trust, you can work with each other and move it with forward faster with more heads rather than just the one. So when you think about your ideas, I gave the example of the clinical scenario of that patient in the emergency department asking me, how long is this person going to get better? Sometimes your clinical questions are, well, why do we do it this way? Why do we tell people just to rest? Seek out the practice variation. I did a survey across both emergency physicians and family physicians in Ontario, seeing what their recommendations were for return to physical activity and return to rest. And there was a large practice variation, which is an opportunity to improve how we do things. Discussing with colleagues, discussing with mentors, another great way to get ideas. We talk about scanning the journals, and it's not just scanning the journals, but scanning things like clinicaltrials.gov or other things that have a registry of funded projects, sometimes in order to see if someone's about to embark on your same project. And then attending meetings, and that's where I'll put another plug in for the NABIS and similars. You may get some ideas. Someone is doing something amazing in more moderate or severe TBI, but the deficit for which they're examining maybe is a cognitive and has a huge applicability to concussion as well. That's a great opportunity to say, if it worked in A, maybe it will work in B, and cross-pollination of ideas is so valuable. When you take on or tackle a project of research, it's important to do things that you find interesting. Things never work really well when you get voluntold how to do them. So if you are working with trainees, I implore you to really put that effort of saying, even if you need to give them a data set, giving them the guidance and say, well, here's 5 or 6 or 7 ideas within this data set. Which one do you want to work on, rather than you're going to work on this one project? And make sure the interest is not just to you and your smaller team, but just general, because you may have the best discovery in your opinion, but if it's only relevant to your center in your state or your province, it's going to be harder to publish broadly or generalize that beyond your local area. And then we talked about the opportunities. Those things are timings, issues, resources available. Sometimes the resources are not just money, but it's the number of participants. If there's another study and all the patients with moderate to severe TBI are being recruited for a brain cooling study, it may be hard for you to enroll them in your study, which is a pharmacotherapy intervention, because of the fact that it's going to be hard to enroll one participant in both those very different studies with a lot of demands on the patients and clinicians' time. And then feasible. And that's why doing pilots is so important too. You may say, this is a great study, but let me start with the pilot to make sure this makes sense. And then relevant, we talked about, how is it going to impact patients, or how is it going to impact the healthcare system? What are the implications if you're right? That's something to really think about. Sometimes we don't think about this as much. Like, is this going to make change? Is this going to completely do a shift in how we think about things? So I talked a lot about getting up with your questions. Now, who do you work with? I really think it's important to work with a team, work with a network, work with stakeholders, but also when you build your team, make sure to incorporate fun. Some of the most important parts of the conferences and meetings and network meetings you attend are not just the scientific sessions, but the sessions in which you're having dinner, or maybe you're all going out to go doing a sporting activity, be it a hike or walk, or even if it's a conference that has a pool or a hot tub, just sitting around and chatting during downtime and getting and bouncing ideas off of each other then. And that's where it's really valuable to incorporate some social things in your team building, because then people know, oh, this person's a great person. I want to work with them. And I know them, and I know who they are and how they are beyond just the formal settings as well. It's also important to realize that nowadays, when you apply for grants, one person is never going to get a grant on their own. You need a team. For example, and I was actually an applied math major in university, and I certainly know how to do statistics, but I'm not at the stage of my career where I'm going to be doing the coding in SPSS or R. You're going to work with biostatisticians who have PhDs in just that, who do that every day and can keep abreast of the biostatistical or methodological literature to make sure that your studies are most designed as well. So it's really important that you work with a team at all levels of the elements of your study. So, one of the things that we have here at our hospital is what's called the clinical research unit. And so I work with the clinical research unit. Even though I have an idea for the study, I still work with them on refining the study design, make sure that the data collection, I'm naming the variables properly, helping me manage the data, helping me do some of the analysis. The other thing is it's really important that it has arm's length. I don't have access to the raw data sets. That removes any risk of changing data sources, and also has good for integrity and reportability in research. And those are important elements to work with those elements of your team as well. Another network that I work with, a lot of the studies initially on and concussion I did through the emergency departments of the PERC network, and I'm very happy and proud of this network. I'm the chair of it. I'm in my last week of being chair. We have our conference next week, and I've had been 4 years of past chair of vice chair and 4 years of chair. And so after 8 years in those vice chair and chair roles, I'll be passing on the baton. But we have 15 hospitals across Canada, and it's multi-center, multidisciplinary, and it's one built on trust. And I'm sure there are similar things for each of you to think about. What is your question? And maybe you're a speech and language pathologist, and maybe there is a national network of speech and language pathologists, or maybe you're a physio, and there's different groups where you can work and share resources, share experiences, work collaboratively and in a trustworthy way, and network with colleagues with like-minded. And rather than you trying to come up with a study that requires 15 years to recruit your 500 participants, you can work with 10 centers and get them recruited in a year and a half. Another network, just as an example, is the Canadian Concussion Network. I'm only giving these examples because that's where I'm currently based right now. But again, this is a network that was fairly new. It shows you that you can establish new networks. There's 50 key stakeholders as well to help respond to the challenges of concussion. And now there's a national research and KT agenda through this CCN in order to really improve the health of not just Canadians, but our discoveries and make it worldwide. I've been leading the pediatric concussion guidelines for over 10 years now, and it's a team of over 40 people. And you'll see it's not just a Canadian team; it's a North American as well team. And that's an amazing way, people bringing in different perspectives and feedback as well. So maybe I'll talk a little bit more about my, one particular study that many of you may be familiar with that I led, but it really exemplifies how I went through these various steps, and that's the 5P study. So to answer that question of when's my child going to get better, we didn't know the answer. So what I did was I got a planning grant, and planning grants are not a lot of money, $20,000. But I was able to bring in several world experts, flew them into Ottawa, had roundtable discussions for 2 days, talked about how to design a clinical prediction study, brought in people who actually had done prediction studies that were different than concussion, but did it in, for example, Ottawa is well known for this. Like if any of you do physiotherapy, you maybe know of the Ottawa ankle rules, the Ottawa CT rules, or the neck rules. And so we brought in people who had come up with rules for these other diseases to give their experiences. We brought in parents and patients, and I even invited that dad who had asked me why we didn't know the answer, and he gave his experience. It reinforced why we're doing the study, and it also gave some feedback on how we informed our study with regards to what outcomes we should be focusing on, where these parents really enforced the importance of function, and earlier outcomes are better than later, to reinforce it's important to intervene early. And we had biostatisticians to make sure that what we were doing was going to be feasible, and we were powered to answer that. And by the end of those 2-day meetings, we had concrete plans for the next step, which became the 5P study. So the 5P study is predicting persistent post-concussive problems in pediatrics. And the goal was to derive a prediction rule using clinically available factors. So this study was not meant to be a biomarker study or a neuroimaging study. It was meant for someone in a small community hospital or a clinic or an emergency department could take these factors and predict whether a patient was lower risk or higher risk for having ongoing symptoms. But you start your study, and it's important to think about nothing's ever going to go perfectly. So one thing is, even your things of your strengths can sometimes be a weakness. And that's really, we'll talk about Goldilocks later, but you don't want, life needs to be in balance, and same with research. So one example of a challenge that I never anticipated was the first day of the study. Our RAs were so eager to get started. At one site alone, they recruited 20 people. And our total sample size for the whole study was 3,000 concussions total. And at that pace, at one site alone, we'd be done in a matter of weeks. which seemed amazing the first day, but then we realized when they're doing 20, they were so eager to get the next, they weren't really ensuring that patients understood that they were going to have to do follow-ups of 1 week, 2 weeks, 4 weeks, 8 weeks, and beyond. And therefore, when it was time for the 2-week follow-up, some of the patients were, no, I think I'm done now. They weren't as interested, and follow-up data wasn't as good. So it was making sure you had the right amount of emphasis on getting as many people as you could at recruitment, but also making sure that the people you got were committed to being on part of the study. And the way I was figure this out was a week or two into the study, when we saw that some of the initial follow-up data wasn't as good, we reached out to the RAs and figured out what, bought them pizza, sit down for lunch. Hey, here's free pizza. Tell us what you think's working well. What do we need to fix? And it's not me telling them what needs to be fixed. It's me listening to the boots on the grounds people, telling them what's working well. And one of the things we realized is sometimes people weren't getting their follow-up emails. So one thing we built in was a little quick check. So the minute they got enrolled, we told the family, hey, open up your mail account on your phone. We're going to send you a test right now. Make sure it doesn't enter your spam mail. And it didn't happen a lot, but about one in 4 people that would be in their spam, they'd go in, add it as a trusted email address, and then therefore all their follow-up. But that was a tweak from our RAs to say, hey, this was an easy solution we could do now. So that's a perfect example. When you do your studies, don't just always think you have the answers. Get ideas from the people who are different strains from yours. Just to tell you a little bit more about the 5P study, we recruited people 12 hours a day, 7 days a week across 9 centers across Canada, collected data real time into iPads using what's called RedCap. We did these follow-ups weekly and then switched to monthly thereafter. And then for the centers, we did face-to-face neuropsychological testing. That was like a 2 to 3 hour battery at 1 month and 3 months. If you're curious, what were the elements of the questions we asked, what were the elements of the neuropsych battery? We did publish the protocol with all the tests that we did. I guess it's now more than a decade ago in the BMJ Open in 2013, and that's a free access, open access paper to download. So as I said, we did enroll over 3,000 people. We did publish the study in JAMA back in March of 2016. You have the QR code. And what we found was that there are factors that predict persistent symptoms. And while you may say, well, what are they? It's how do you define your question? There was actually over 46 factors that were significant predictors. And that's why there's probably so much heterogeneity in the data. The other reason for the heterogeneity of the data was there's also homogeneity in the previous patients. The previous literature until this study had focused primarily on male athletes, high school football players and high school hockey players doing collision sports. Whereas this study looked at all youth. They could have fallen at the playground, they could have slipped on the ice, they could have been assaulted, they could have been in a motor vehicle collision, and hence it's much more generalizable. We also do not exclude for things like ADHD or behavioral problems, which are very important risk factors for concussion, as well as risk factors for prolonged symptoms. And so we had to make something pragmatic. And so what we did was we came up with using the Sullivan Index, which is the same sort of methodological approach that was used to come up with the Framingham Heart Risk Score, in which going into math here, but the beta coefficients of the odds ratios get transformed into the number of points. So I'm going to show you the next slide. That's why some points are a 0.1, some points are a 0.2, and some are others. And it's not just me picking what the points are. But if you really think about 5P, it breaks down into 5 categories. First category is demographics. So older the child was, the higher risk they were of having symptoms at 1 month. Females were higher risk than having ongoing symptoms than their male counterparts. That's the first, is a demographic. The second category is their past history. As you will see, the number of concussions they had, some of the other factors, the type of sport, some of those other history factors were not predictors. Once you did multivariable regressions, it was did you have a prior concussion? And if so, did it take a week or more to get better?
And if you did have a prior concussion and it took a more than a week to get better, you were higher risk. If you had 2 prior concussions or 3 prior concussions, but every time you got better in 3 days, that was not an elevated risk of having it prolonged the next time. Personal history of migraine was also an important factor. We did a lot of cognitive questions. We did all the cognitive testing that was built into the SCAT at the time. So we did digit span, word recall, memory questions. None of those were predictive. Even adjusting for age and doing transformations to know that a 5-year-old's not going to do as well on a memory test than a 17-year-old. None were predictive. The simple question to the bystander, was Timmy answering questions slowly? And the mom said, yeah, he seemed to, like, I asked him a question and he'd pause and think about it and then give me the answer. That alone was as good or a better predictor. And it was an early sign. Speaking of early signs, you'd also see that loss of consciousness was not in there. Seizure was not in there. We looked at all those. They were not statistically significant factors when put into a multivariable regression. We did a whole bunch of balance and other testing. That tandem stance, the tandem stance is you have the person stand, they kick the dominant foot ahead. So I have to say, pretend there's a soccer ball, give it a kick. If they kick with this foot, that foot stands in front of the other. And then it's hands on hips and close eyes for 20 seconds and see how many errors they have. That tandem stance of all the physical exam things were most predictive. And although we asked 20 symptom questionnaires, it was the presence of headache, sensitivity, noise, and fatigue that were the most predictive. I find them very interesting as well, because I personally think a lot of these things overlap with autonomic dysfunction, and that is a major interest of mine and John Letty, who's a partner and research of mine as well, and thinking about autonomic dysfunction's role in concussion symptomatology does overlap with, interestingly, with those symptoms. And the reason we don't put all 20 in, it's going to take 20 minutes to determine who's going to have symptoms or not. And if any of you worked in an emergency department, you don't have all that time to spend. So you make your diagnosis. What used to happen was they were told, just rest until you're better. Don't go to school. Don't do exercise. Do nothing until you feel symptom-free, and then you can go back doing what the things that you need to do. And people would interpret that as home jail, because people did not necessarily become symptom-free. And so that actually probably led to a lot of harm. People were feeling disconnected, socially isolated. That may increase their anxiety, which would then create a downward spiral of perhaps depression or dysphoria. And those were really, I think, causing more harm than good, this concept of rest until fully symptom-free. So my next recommendation is don't be afraid to think outside the box. I mentioned John and Haley and I were talking about very earlier. It's really important to think about things that went against the grain. You don't do it to be contrarian. You do it to go back to that question. Well, why do we do it this way? And so one of the things we were doing around the same time that John and others were looking at exercise was, well, we said, well, does early exercise associate with recovery or time with symptom duration? And we did and found that there was a strong association between those who returned to physical activity within a week had much less lower risk for persistent post-concussive symptoms. And that was still there even after you've done matched for all their propensity to do physical activity. So if you say, oh, if you only design your study, the person who's symptom-free and the person who's not, of course you're going to see those who got better faster, did exercise because they were better. But we matched people who felt crappy with those who felt crappy and those who felt great with those who felt great, and we saw how they did, and with all the other factors as well. And also published this in JAMA. I would say of all the papers I've done, this was the most statistically challenging, and there were things like propensity score modeling as well. But if you're curious, I put the QR code if you want to read more about it. But the JAMA said, even though it's JAMA, it's may change the guidelines, we really say you need to confirm this with an RCT. So just to, as I mentioned John earlier, here's a picture of John. This is a slide that John has
This comes from adapted from a paper that John did called Exercise as Medicine for Concussion. And these are the benefits of exercise. Autonomic dysfunction can help your autonomic nervous system balance and carbon dioxide sensitivity. Exercises improves your cerebral blood flow regulation. Exercise promotes neuroplasticity by increasing your BDNF. By exercising, lots of studies have showed you have improved mood, reduced stress. That may even help with your sleep and reducing fatigue, and your cognitive functioning improves. And that's unrelated to any injury. They've done studies of kindergartners who do jumping jacks and then take a math quiz, and those who just sit quietly and take a math quiz, and those who do the jumping jacks before do better. So lots of evidence to show that outcomes are better after getting your heart rate up. And so that's where I think it was important for us to continue to do this. And so it ties into the recommendations, because this is one of those things I talked earlier, as you build your program of research, some people may strongly disagree. And I know John has felt that. And even when we came out with our early physical activity, there were people who were very much so that disagreed with that, saying you're going to have kids who are getting hurt too early, et cetera. And we weren't saying do any exercise. We were saying do low risk. So we decided to back it up and not sweat the small stuff, but decide these are things that we want to follow up on. And so we did a study called the PED-CARE study, where we randomized kids to, on their own, not through a guided clinic-based progression, but on their own, do self progression up until the point where they needed medical clearance for the high-risk activities to see if it was safe and did it reduce symptom burden. And that was called the PED-CARE. Again, it was through the PERC network. And we found that it did lead to, first of all, it's safe. And for those who were compliant with the protocol, it led to lower symptom burden at 2 weeks. So I think that's a good example of just continuing to stick with it, build your program of research, and build your evidence space. And now I think all of us would agree that exercise is now the standard of care in concussion. So I'm going to shift gears here. Maybe I'll pause for a second, see if there's any ones with questions in the chat. If not, I'll move on to the last little bit of the slide talking about of managing a program of research. Anything, Haley, or I'm good to keep moving?
You are all right to keep moving. I've been monitoring for you, and we're good right now.
Excellent. So as we move forward, as I find some of the best ideas come from your trainees and your students that you work with. So I don't think this is just a one-way, the mentor teaching the trainee. I learn as much from my trainee as much as I hope that they are learning from me. And I think it's important to recognize and acknowledge the value of trainees in your team. And here's a perfect example. Zuzana Novak was a medical student of mine when she published this paper in JAMA Peds. It's been the only one of 2 papers, I'm almost up to 200 publications in my career, one of only almost 2 papers in which, sorry, I want to show you this, in which she was able to get an acceptance on the first submission. No revision required. It was like, yep, you're accepted. It was that she did that great a job on it. So I wanted to call out Zuzana and her amazing job on that paper. But this was just another study that talks, again, when you talk about funding, well, we showed that having a concussion can affect your quality, or can be associated with changes in your quality of life. And just to describe what I mean by that, the blue horizontal lines are quality of life norms in pre-published data using the PEDS-QL. And it's in 4 domains: physical, emotional, social, and school. The participants that have the blue squares are those who had concussion, but in whom their concussion symptoms had returned to pre-injury baseline by a month. And the triangle are those who took a month or more. Now, that does not mean to say that they were still symptomatic at 3 months. They could have taken 4 weeks and 2 days, but they would still then end up in the triangle group because they were beyond the 4-week time point. And so, as you can see, if you get better or back to your baseline within a month, you will have normal physical, emotional, and social quality of life compared to those who've never had, those who are just in society without a concussion. However, if you're not improved from your
concussion by 1 month, your quality of life can have significant implications and low function at 1 to 3 months and even beyond for these important domains of quality of life. And most importantly was the school. Even if you got better within a couple weeks, you were still within 3 months having very low function of your quality of life, which is one of the things, when I'll talk about in a moment, I was a big proponent of getting kids back to school earlier, even if it's not to take exams or to do their full course load. So we'll talk about that in a moment, but that's going to be an important thing that drove this was important for us to address. I do think it's important to, when you're fostering that next generation, working with others, to share generously. And make sure your data sets are not just to do your one study and move on. There's probably 5 or 6 questions that every single data set at minimum can answer, or at least be used to explore other novel hypotheses. So this is not mine, but this is the research cycle that I'm a big proponent of. And it's one in which you're doing your data collection, maybe for your current study that you're working on. But at the same time, maybe your team is also analyzing a sub-study of the study that you just published. And maybe there's someone else, or you're also writing a manuscript of sub-study 2 of that same paper. And because you saw some of those interesting patterns in your hypothesis generation or some of the other work, you're writing a grant application to look at the next step, which is perhaps a return to school or something else. So you need to be theoretically working on a little bit of each of these elements of the cycle at any time in order to keep that engine churning, to get new applications in, to give you new data to collect. And when a trainee joins a team, they're able immediately to join, at least in the analysis and the writing part, even if there's going to be a while for the data collection to be done to write that up. I also think it's important to share your data, not just with your team, but beyond. Putting things in open science when it's able to do so really improves your transparency, enables collaboration. And I've done that. And that 5P data set that I talked about with almost, I think, over 1 million data points total has been uploaded into BrainCode. And so if you went to the Ontario Brain Institute BrainCode website, you can request access if you're affiliated with the university. There's a whole questionnaire and there's a whole process to get it, but you can get the outcomes from these 3,000 plus participants through the process with Ontario Brain Institute to leverage the data that's been collected. But again, that works with trust. It's trust has to go both ways. So I think it is important. This is a quote, trust is the glue of life. It's the most essential ingredient in effective communication. And that's from Stephen Covey, who wrote the book of Habits of Highly Effective People. And so how does that trust work? Well, these are examples of some other studies that we've done leveraging that open access. So the CDC worked with a team with Jerry Joya, and they're developing a smartphone app that's called On Track. We've partnered with the team out of UCLA that looked at motor vehicle collisions versus sports as a sub-study. I've worked with Rebecca Mannix and Todd Lyons, who are peds emergency at Boston Children's at Harvard, and we did a phenotype cluster study. I've worked with Chris Vaughn and Jerry Joya, and we did a study that showed that getting back to school early leads to better outcomes. And these are all things in which all 4 of these had different first authors that weren't necessarily part of our original 5P study team, but it still leveraged all that data and has led to some great outcomes. And here's the example of the study that Todd and Rebecca led, again, still with many members of our team involved because they wanted the input. But these things were really interesting. We did what's called a hierarchical agglomerative cluster analysis, and that's a mouthful for still early in the morning. But long and short, it shows that there's probably about 40 different phenotypes of concussion. Some may be not really having a lot more physical symptoms or even autonomic dysfunction symptoms, but they are really presenting maybe more with fatigue, or they're presenting more with emotional problems, or there's some people that are presenting a lot with primarily autonomic dysfunction problems, like these people here. So this is an interesting way to explore. Are there ways in which we can take this type of things, predict what type of cluster they're in early, and then target interventions based on personalized presentations? And so with that, I think it's important to maybe almost start wrapping up. One of my take-home points is, if you're early on in your career, don't be afraid to say yes. Too many people say just say no to everything, focus. I think at the beginning of your career, work with lots of people, say yes. You'll then have things to think about as you finish those projects or those things that you do or don't want to be working on. But as you move to late in your career, you do unfortunately have to start to say no sometimes, because although you're going to be passionate, you only have so many hours in your day, and you need to make sure that you can get your things done that you need to do. Just a quick couple plugs for the team work that we're doing. We have our pedsconcussion.com, which here's the web link. That's our living guidelines. It's amazing how much things have evolved over the 10 years from our first edition to now. If we were curious about those return to activity protocols and some of those things I talked about, return to school, return to sports, all those are now in the updated guideline. As I said, it's an amazing team. And I think that's where it's really important that whatever we do, those discoveries need to make it to the bedside. And this is a study that Keith Yates led that I was part of. It basically took the 5P score that we did. This was the plugin that I had made for my hospital, in Epic, in which I now see a patient, I just go click, 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 click when this smart phrase pops up in Epic, which is an EMR that we use at our hospital. I shared it openly with many centers, one of which was the entire province of Alberta, and Keith Yates and his team plugged this into every emergency department across the province and came up with a pathway using a cluster trial based on center to incorporate this 5P into a provincial pathway. So with that, I think it's important to know that it's important your discoveries make it to where they need to go. The last thing is the future. What am I keeping busy with now? I am keeping busy with this new study called Transcendent. It's called Transforming Research by Assessing Neuroinformatics Across the Spectrum of Concussion by Embedding Interdisciplinary Data Collection to Enable Novel Treatments. That's what we're going to call Transcendent. What are we going to do? We're going to be doing lots of parallel studies. Hypothesis-driven trials, comparative effectiveness research. We're going to work with industry to come up with better diagnostic tools and therapeutic tools and prognostic tools. Hopefully implement those into pathways and guidelines and care approaches to personalize and tailor the right care for the right patient at the right time. What are some of the things we're going to be exploring? Well, one of the interventions that we're doing right now is an RCT of mindfulness. We're going to be delving more into the autonomic dysfunction using tilt table testing. We're going to be looking at eye tracking using tools and devices that better perhaps do thousands of measurements per second rather than just following a finger. We're going to be looking at fluid biomarkers and advanced neuroimaging. So really exciting. It's going to be, we're funded for the first half of the project it's a 5-year project, but they're releasing funding in chunks. And even just over those first 2.5 years, it's over $5 million. So we're really excited to do this work, and it's what's keeping me very busy. And with regards to my last take-home point is to be humble. And this is Albert Einstein himself who said, the more I learn, the more I realize how much I don't know. And I feel like that every single day I'm working in the field of concussion research, and it's what keeps the passion and keeps the curiosity. So big picture take-home messages: ground your research on important questions. Make sure you do your homework beforehand. That's called the pre-search. Ask the right questions, get the input, make sure the opportunity is right for you and that it's feasible and relevant. Work with the team, build the team, and trust your team. Even if possible, work with your networks and share openly. When you get your discoveries, don't just think it gets into the publication and ends. Make sure it gets into guidelines, make sure it gets to the bedside, make sure it gets implemented. and always remain curious. So with that, I will stop my sharing and see if people have any questions. We still have about 10 minutes, I think, left for questions.
Yeah, thank you so much, Dr. Zemek. That was a wonderful presentation. The chat is open if you want to post any questions. And I'll give you guys a second to put your questions into the chat, and then I'll read them to Dr. Zemek. And while people are thinking about what questions they will ask, I'll start with one of my own first. I wanted to know if you had any suggestions on engaging different populations. So I took that QR code from your slide earlier on patient engagement. And I specifically, goodness, was wondering if you had any suggestions for understudied population, because that's a large criticism of concussion research, is that we don't always engage those understudied populations.
So I think it's such an important question, Haley, and I was even looking at the tag. It ties into it. Our study is not just looking at youth. It's going to be collecting data at this network of interdisciplinary clinics across the province that's going to be adults. And there's going to be people who were injured in the workplace. There are going to be adults who fell. There's going to be people who are victims of intimate partner violence. And for that, I think a perfect example is one of my collaborators on the study is Cheryl Wellington. For those of you who don't know Cheryl, she's not a clinician, but she's a accomplished professor in cellular biology at University of British Columbia. And she is working with some of the women's shelters to get data on women that are victims of intimate partner violence, knowing that it may not be safe for them to come into a clinic. It may not be safe for them to do some of those those components of testing or components of data collection, or components of research engagement is a lot harder for some of these populations. And so she has been helping to pioneer, along with some of her team members, ways in which some of those participants can be engaged. I also think it's important to think about those who are beyond just our typical, let's call them elite athletes and military. So thinking about, where do you normally work? If you normally work at a center that's affiliated with like a university sports team, you may say, okay, how else can I get participants for my research? Maybe my control group's not orthopedic injury. Maybe my control group is those who have sports injury, but the group I'm really interested in are those who had motor vehicle collisions, or the groups of that. And that's where working in an emergency is, at least for me, an interesting opportunity, because you do see the full spectrum of humanity come through an emergency department. And same in the US as well. You can't turn away anyone at the door. Anyone who shows up to emergency, whether or not they have insurance, whether or not they must be seen and treated. So now, will those people participate in research? Well, maybe that's how you think about designing your study, so that you can get it all right then and there. So maybe your emergency study is not to say, how do you do over months and months and months, because that's going to be harder. Are there things that you can do while they're right then and right there? And some of it may be qualitative. You can ask them some questionnaires. You can engage them and get some of their input on things that could answer some questions that are less understood about that population.
Yeah, I think that's very important in regards to engaging participants. That was another question I had written down as well, in regarding to keeping that buy-in to get people to engage and follow up. You mentioned that one study where you lost a lot of people and how we can rectify some of those issues. And I think that's very important, especially when we're dealing with those topics that might be slightly controversial. How do we get that participant buy-in? There is a question in the chat that I do want to address before asking some of my own questions. Ilana, and I think you've actually touched on this already, but Alana is asking if your new project is pediatrics focused, or does it include adults as well?
Yeah, it's going to be. Thanks, Alana, for the question, and thanks all of you for attending today. That new study is going to be basically from as young as toddler up to as long as they're old enough to still make it into clinic. So I think the clinic's seen people in their 90s, and that's a really understudied group too. Especially, how do you diagnose concussion in a person who maybe already have some memory issues that have gone along with aging as well. And so those are some of the things. Or how do you assess balance? And the person in whom balance in your 90s at baseline is not going to be normal. So doing a BAS on a 90-year-old, if you just went into
a long-term care home or a assisted living home and check balance on every one of those 90-year-old residents without an injury, you're going to get abnormal balance on those people too. So how do you identify, diagnose, prognose? What are the things important for them? They may not be interested in getting back to hockey. They want to be able to walk down the hallway without risk of falling. Or they want to be able to cognitively maybe be able to be engaged in just doing a Zoom call with their grandkids who live far away, but getting on the computer is really hard for them right now because of the vision or the tracking. So what are their outcomes? I think it's really important when you talk about that. I want to give another example of how you engage and keep patients. So one, you can never coerce people or do that, but you do need to compensate them for their commitment. So how do you do that? Sometimes small little incentives. So sometimes when everyone does a follow-up, they get a $10 or $15 gift card, or maybe if it's a thing with a longer study, you say, if you've done X% of them, or you've done this one, you get the $30 gift card or the $50 gift card. When people have to come into the hospital and get things like a scan done, like for the advanced neuroimaging, we always pay for their parking, to get someone to have to pay for parking, and to that, for patients, as well. Sometimes we even did things where we can give a bigger prize, but it's like now a lottery system. So the first 100 people of the study will all be who've completed their outcomes will be put in a draw for an iPad or something like that. And that's another way of doing it. So it's not like you do it, you get an iPad. One out of 100, every 100 will get an iPad or something like that. So those are things. When it's students, a lot of students in Ontario need to have volunteer hours to graduate from high school in Ontario. And so giving them a certificate. So for you figure out what their participation was, every questionnaire they did, every tracking they did, add up those things and add up the number of hours, then you write a certificate that's official volunteer hour contribution, even though they're still getting their small incentive as well. Lastly, with regards to getting patient feedback, that PCARE study, we did accelerometers to measure their speed of their intensity of exercise, was light, moderate, or vigorous physical activity. We have another paper coming out very soon. I don't think I can break the journal's rules, but it was just accepted and it will be coming out eminently. But it was looking at, what's the right balance for the intensity of exercise. But we found that the patients didn't like wearing the accelerometer on their hip. They had to wear it on the outside of their clothes, or if they wore a skirt, they didn't have a belt. So just thinking about solutions and thinking about ways to work with patients and families on, even just the protocol, how can we tweak the protocol to make it work for them?
Yeah, I think those are all really great and important points. And I'll even add a story that we just experienced here in Buffalo. Recently, we were thinking about compensation for one of our upcoming studies. And as you mentioned, here in Buffalo with Dr. Letty, we do a lot of exercise-based studies. Our compensation, we decided, was going to be Fitbits. We were using Fitbits for the study. They would take home the Fitbits. We piloted that with some subjects. And we said at the end of the study, here's the Fitbit. And all of our pilot participants denied the Fitbit because they already owned them. They already had Apple Watches or Fitbits or polar heart rate monitors. So we were like, oh, we need to change this. So things like that, I think, are very important to think through. And sometimes, as you mentioned, we come across these problems while the research is in development. So it's always good to be able to go back and reassess and, evaluate your plan. We have about 2 minutes left, so I'll ask one more question and then we'll end our session there. But I wanted to see if you had any more insight regarding dissemination. You mentioned going to journals, going to conferences, and disseminating information. And I feel like particularly a lot of researchers have had trouble finding the correct journals or, disseminating their information in a timely manner. And I was wondering if you had any further insight on that.
So I think that's always such an important question. I think every study is going to have a different target journal. Sometimes in my research, I focused on emergency journals because I really want the emergency doctors to do this a certain way. Sometimes it's been in pediatrics because I think it's something that anyone should do. Sometimes it's a brain injury journal. So that's one thing for publications. But I also think it's important to take that to the bedside. So I have spoken at stakeholder groups of groups like IBIA and others where it's patients with lived experience. I've done meet the doc,
community sessions to lay persons on the beginning of a hockey season, the beginning of a sports season, and talk about the importance of awareness and prevention. I've met with like skiing Canada groups and say like, hey, this is, if you're a coach, I met with coaching groups like, hey, this is how you recognize a concussion, and this is how your athlete needs to progress through stages. And here's some things that you can maybe do to prevent an injury. You know, here's some smart warm-up techniques, or here's some things in your drills. You know, volleyball, one ball at a court at a time. Don't have 5 balls on the court at a time during warm-ups. That's when people get hurt. So it's taking and being willing, and as I progress in my career, it's not just always the one person has to give all the talks. It's giving others opportunities to share that as well. So it's not always, you know, the Roger Zemek or a John Letty or a Chris Giza or whomever it is giving the talk. Sometimes it's a member of that team, especially if they're a trainee or a student, say, hey, why don't you give this talk to this group? It's a great opportunity for them to get a presentation. It's just more people getting the word out, and hopefully advancing the care of the community that we serve.
Yeah, absolutely. I couldn't agree any more with that. And with that, we are at 12 o'clock, so I'll end the session here. Thank you so much, Dr. Zemek, for presenting, and thank you to the group for stopping in and listening to the presentation today.
Thanks for having me. Hope to see you all in Las Vegas.
Thanks, everyone.